Welcome to Breast Cancer Breakthroughs. Immunotherapy is a cutting-edge type of treatment that jumpstarts your body's own immune system to fight cancer. Historically, people with triple-negative breast cancers, or TNBC, have had few options beyond chemotherapy since they lack the estrogen receptor, progesterone receptor, and the HER2 protein, all of which can be targeted by other targeted treatments. However, immunotherapy has become an important treatment option for some people with triple-negative breast cancer since it was first FDA approved for metastatic breast cancer in 2020. While immunotherapy combined with chemotherapy has improved outcomes for people with TNBC, researchers have wondered, could it be better? In today's episode of Breast Cancer Breakthroughs, we speak with former Komen Scholar Dr. Melinda Telli to tell us about the role immunotherapy plays in treating triple-negative breast cancer and how researchers are continuing to optimize this type of therapy. We also speak with Dr. Stephanie Graff to discuss ongoing research that is taking a new approach to immunotherapy in triple-negative breast cancer. We asked Dr. Telli to explain what immunotherapy is and how it works.
Our immune cells, particularly our T cells, have an ability to recognize cancer cells and kill them. And so immunotherapy really tries to harness this natural ability that our immune system has to protect against and fight against cancer. Immune checkpoint inhibitors are a specific type of immunotherapy that really is trying to control the T cells and how they are activated or suppressed. And so these immune checkpoints are really, really important to help to control that immune response. And there are many of these checkpoints, but one that became very well known and very important in the cancer world is this PD-1, PD-L1 checkpoint. So PD-1 is a protein that's present on T cells, and when it binds to PD-L1, it sends a signal for that T cell to be suppressed. And so cancers have evolved to express PD-L1 on their surface, and sometimes it's not actually on the tumor cells, but some of the cells around the cancer. But when it's present, it can essentially inactivate the T cell. And so the idea was that if we made drugs that could block that interaction between the T cell and the tumor cell, that would then allow that T cell to be free to go in and attack the cancer. And so there were antibodies that were made against PD-1 and PD-L1. And in breast cancer, we have a PD-1 inhibitor approved, and that drug is pembrolizumab, also known as Keytruda.
To learn more about how immune checkpoint inhibitors work, check out our video linked below. Immune checkpoint inhibitors are currently approved to treat TNBC, but not other types of breast cancer. Dr. Telli explained why this is and explained the role that tumor PD-L1 plays in guiding treatment with immune checkpoint inhibitors.
One of the reasons why triple-negative breast cancer was really picked as a lead subtype for us to go after in clinical trials was because we know that compared to other breast cancer subtypes, triple-negative tumors, they tend to have more immune cells in and around the site of the tumor. And so we think about this as sort of an immunologically hot environment. The immune cells are there, and can we unleash them to fight the cancer with the checkpoint inhibitor? But certainly triple-negative breast cancer was the place where we focused, and that ultimately led to the approval of chemotherapy and pembrolizumab for patients who have advanced triple-negative breast cancer, previously untreated for advanced disease, And the initial trials, we included all patients in those clinical trials. But what we learned is that the checkpoint inhibitor really benefits a subgroup. And so that's a subgroup of patients whose tumors have the PD-L1 marker present at a certain level. And so the current approval for pembrolizumab for advanced triple-negative breast cancer, it is a treatment option today for about 40% of patients with recurrent or metastatic triple-negative breast cancer. It's a little different story in early stage triple-negative breast cancer. Once we learned that pembrolizumab was effective there, the next set of trials looked at high-risk patients with localized newly diagnosed disease, so stage 2 or 3, and patients received chemotherapy alone or chemotherapy with pembrolizumab, all given prior to surgery. And we have shown over time that this improves response rate at the time of surgery. It reduces recurrence, and most recently, the data have shown that it improves overall survival. So it's been a huge advance in early triple-negative breast cancer. And what's interesting there is that the pembrolizumab benefits all patients. And so it's not just a subgroup of the patients. So for patients with stage 2 and 3 triple-negative breast cancer, there isn't a need to test for PD-L1 expression, where in the recurrent setting, that is really important to identify the group of patients who are going to benefit.
While immunotherapy has improved outcomes for people with TNBC, researchers believe that there is room for improvement. Dr. Telli explained different approaches researchers are taking to unlock the potential of immunotherapy in TNBC.
The other big class of drugs that have been really important and lots of activity going on in that space is with the antibody drug conjugates. So these are sort of chemotherapy drugs that are linked to antibodies, and those antibodies help to hone the chemotherapy to the site of the tumor. And so there's a lot of interest in looking at these antibody drug conjugates, combining them with immunotherapy. There are a lot of trials in this space looking at TROP2 targeted ADCs. So again, we have sacituzumab govitecan that is currently approved, but a couple of others, the datopotamab deruxtecan, and then the sacituzumab tirumotecan, sac-TMT. These are other drugs that are in phase 3 testing right now. There's some new types of immune therapy drugs that are in early clinical development, but really rapidly moving forward. These are antibody-based treatments, but they're bispecific antibodies. So instead of targeting one protein like PD-1 or PD-L1, it's targeting two. There are also other antibodies that are kind of multi-specific, trying to target even more than that in terms of the number of different proteins. But we've seen some super exciting data from early phase studies looking at a bispecific antibody. There are actually 2 lead compounds that are moving forward. One of them is a drug from BioNTech, BNT327, which is a PD-L1 and VEGF inhibitor. So VEGF is the vascular endothelial growth factor, and we know that tumors, to support their growth, they need to recruit blood vessels. But these bispecific antibodies are sort of combining sort of a blocker of VEGF and a blocker of PD-L1. And we have seen really very exciting data, high response rates in patients with recurrent or metastatic triple-negative breast cancer treated with their initial treatment with chemotherapy and this BNT327 drug. And what's really exciting about it for me is, again, that we are seeing activity across all patients and not just the subset of patients with PD-L1 positive tumors. I think the other really big area that it's all very new, but it's around cell therapy. So we've learned in the liquid tumors, leukemias and lymphomas, that some of these cellular therapies, like CAR T therapies, have really been really game-changing for patients with recurrent leukemias and lymphomas. And so there's lots of work to look at moving some of those concepts from the liquid cancers into the solid tumors. So, we're really excited about different approaches to cell therapy. There's been a lot of interest in having better markers to identify who are the patients likely to benefit. And so there have been lots of work going on looking at different immune-related gene signatures to identify tumors that would be more likely to benefit, with some clinical trials ongoing in that space. There's also been just kind of something very simple, looking at the number of immune cells that are present in and around the tumor and counting that. And certainly we have a lot of data showing that it's really prognostic and can also predict for benefit from these checkpoint inhibitor immune therapy approaches. There's also interest in looking at biomarkers to better identify which patients may be at elevated risk of toxicities from immunotherapy. But when we are revving up these immune cells, one of the big things that we can see is immune-related side effects. So these revved up T cells can cause inflammation in different places in the body, virtually any organ in the body. And so there are some of these immune toxicities that, can really be serious. Fortunately, they're uncommon, but there is also a lot of work going on to try to figure out if we can identify patients who may be at elevated risk for some of those toxicities. So definitely a very active area of research.
One way that researchers are unlocking the potential of immunotherapy in TNBC is by combining immunotherapy with antibody drug conjugates. The Tropion trials are a group of trials taking this approach with TROP2 targeted antibody drug conjugates. You can learn more about how TROP2 targeting antibody drug conjugates work in episode 4 of Breast Cancer Breakthroughs, and by checking out our explainer video linked below. The Tropion trials are combining an antibody drug conjugate called Dato-DXd or Datraway with a PD-L1 inhibitor called durvalumab or Imfinzi. These trials are testing this drug combination in several treatment settings in TNBC, including neoadjuvant, adjuvant, and metastatic. Dato-DXd was also recently FDA approved for metastatic hormone receptor positive breast cancer as a result of the Tropion Breast-01 trial. Dr. Stephanie Graff is a principal investigator on the Tropion Breast-05 trial. She explained why the approach of combining immunotherapy with an antibody drug conjugate has the potential to improve outcomes for patients.
Antibody drug conjugates and chemotherapy are different in how selective they are for the target, which obviously I'm sure the audience already knows and understands quite well, that with an antibody drug conjugate, you have an antibody that's delivering that cytotoxic payload directly to a key target. But as a result of that, we see some differences in the tumor microenvironment that may result in a 1 + 1 = 3 effect of pairing the antibody drug conjugate with an immune checkpoint inhibitor. Because when we use more traditional cytotoxics, it may disrupt the tumor microenvironment differently, making that immune checkpoint inhibitor not quite as effective as opposed to when it's paired with the antibody drug conjugate, which may be less disruptive to that immune microenvironment. So there's lots of, scientific rationale in the preclinical and translational space that suggests that these agents may be, again, sort of mutually beneficial when they're used in combination.
Dr. Graff then explained the gap that trials like Tropion Breast-05 are aiming to fill for patients with metastatic PD-L1 positive TNBC.
As we all know, advanced triple-negative breast cancer, PD-L1 positive or PD-L1 negative for that matter, has a poor prognosis and survival compared to other cancer types and compared to other metastatic disease. And so there is a real need to continue to explore potential new therapeutics Keynote 355, which has been the standard of care, is a difficult chemo regimen. It requires a cytotoxic chemotherapy plus an immune therapy, sometimes a doublet cytotoxic chemotherapy. And I think globally, particularly when patients receive adjuvant or neoadjuvant chemotherapy, sometimes it's difficult to select the best available first-line chemotherapy partner with that regimen, given the potential toxicities that a patient may have from prior therapy or the prior exposures. And then for patients that have progression earlier in their treatment, it represents a potential area of unmet need. So big gaps to fill in the metastatic triple negative breast cancer space. And then as we continue to see success in treating metastatic triple negative breast cancer, of course, our hope is that we can continue to advance those options to earlier lines of therapy.
This approach is already showing promise for patients. The ASCENT trials are another group of trials testing this approach in TNBC. These trials are combining an antibody-drug conjugate called sacituzumab govitecan, or Trodelvy, with pembrolizumab, another immunotherapy. Positive results from the ASCENT-04 trial were recently announced at the 2025 American Society of Clinical Oncology meeting in June. Dr. Graff explained the significance of the result for patients.
We saw the first analysis of the data, which included progression-free survival by blinded independent central review. And we saw that sacituzumab plus pembrolizumab did statistically improve progression-free survival from 7.8 months for the chemotherapy pembro arm to 11.2 months median progression-free survival for the sacituzumab pembro arm, with a hazard ratio of 0.65, which was statistically significant. The toxicity was not additive. It was sort of what you would expect for sacituzumab independently and pembrolizumab independently. So I think that was good to see. But of course, there was a high degree of side effects given both sacituzumab and pembrolizumab. And so I think that trial was a very meaningful result and a very meaningful outcome for our patients. They did also report objective response rate in the study, and we did see a high objective response rate.
Dr. Graff went on to explain how early clinical trial results testing Dato-DXd plus durvalumab in metastatic TNBC make her hopeful about the outcomes for TROPION-Breast05. Together with the ASCENT-04 results, she is optimistic that more treatment options will be available for patients soon.
Interestingly, going back and thinking about TROPION-Breast05, we've also seen the report from Begonia, which was the phase 1b, phase 2 study of datopotamab deruxtecan plus durvalumab in first-line metastatic triple-negative breast cancer. And the objective response rate in that study and the median progression-free survival was also quite promising. And so I think that we're seeing a lot of really favorable activity for these first-line trope targeting agents in combination with immune checkpoint inhibitor. In Begonia, which obviously was, a phase 1 study, much smaller, total of 62 patients received Dato-DXd. The confirmed objective response rate in Begonia was 79%, and the median progression-free survival was 13.8 months for Dato-DXd plus durvalumab. So I think with what we've seen from Begonia, and just the differences in dosing schedule and potential differences in toxicity profile, moving forward with TROPION-05 is still really valuable for our patient community, and still, I again am optimistic is going to open up choice for our patients as we consider how to treat metastatic first-line triple-negative breast cancer. TROPION-Breast05 is a randomized phase 3 study of datopotamab deruxtecan, or Dato-DXd, with or without durvalumab versus chemotherapy plus pembrolizumab in patients with PD-L1 high, locally recurrent, inoperable, or metastatic triple-negative breast cancer. This is in the first-line metastatic triple-negative breast cancer setting, and patients do need to be centrally confirmed PD-L1 positive. Our primary endpoints of the study are going to be looking at, of course, progression-free survival by blinded independent central review. And then the key secondary endpoints include overall survival, objective response, duration of response, clinical benefit rate. And so, I'm hopeful that we'll see a meaningful progression-free survival with the combination and a reasonable safety profile. But we are accruing to reach that endpoint and to move forward with this so that we can collect the data and better understand datopotamab deruxtecan plus durvalumab as a potential treatment choice.
Finally, we asked Dr. Graff what she would say to people with triple-negative breast cancer who may be considering a clinical trial.
The control arm of KEYNOTE-355 continues to be our current standard of care in guidelines and internationally. And so I think that it is a tremendous opportunity to get tomorrow's medicine today, as we like to say, on a clinical trial.
Thank you all so much for watching. We hope you've come away with an understanding of the power of immunotherapy and with renewed hope that new options for triple-negative breast cancer may be on the way. Here at Komen, we are committed to bringing you evidence-based information to empower you to make decisions in partnership with your medical team as you navigate your experience with breast cancer. Don't forget to sign up for reminders for breast cancer breakthroughs. We've linked to the homepage below. And finally, if you enjoyed today's episode, please take 2 minutes to fill out our short survey linked in the description below.